This is a quick review from class for lower respiratory problems. Acute bronchitis. This is an inflammation of the lining of the bronchial tubes, and people who have bronchitis often cough up thickened mucus which can be discolored. Bronchitis may be either acute or chronic. Cough suppressants are frequently prescribed for acute bronchitis. Because most acute bronchitis is viral in origin, antibiotics are not prescribed unless there are systemic symptoms, and fluid intake is encouraged. Whooping cough, or pertussis, is a highly contagious respiratory tract infection. A nose or throat culture is done to check for presence of whooping cough bacteria. Patients may also have a high white blood count. Treatment is antibiotics. Cough medication, sometimes codeine-based cough syrup, can be prescribed. The increased rate of pertussis in adult is thought to be due to decrease in immunity after childhood immunization. Immunization is the most effective method of protecting communities from this infectious disease. Hand washing should be taught, but remember, pertussis is spread by droplets and contact with the secretions. Pneumonia. This is confirmed by chest x-ray, and cultures are taken from 2 separate sites 15 minutes apart to identify the bacteria. Broad-spectrum antibiotics are started, and antibiotics given ASAP to reduce mortality. Increased tactile fremitus over the area of pulmonary consolidation is expected with bacterial pneumonias. You would expect to have a dullness to percussion. Pneumococcal pneumonia typically presents with loose productive cough, and the risk for aspiration is decreased when patients with a decreased level of consciousness are placed in a side-lying position. Upright position would also be acceptable. Frequent turning prevents pooling of secretions in immobilized patients, but will not decrease the risk for aspiration in patients at risk. Nasal oxygen will improve gas exchange, but will not improve airway clearance. Elderly can be given pneumovax and influenza immunizations at the same time, just in different arms. Conditions that increase the risk for aspiration include decreased level of consciousness, like seizure, anesthesia, stroke, alcohol intake, head injury, difficulty swallowing, and nasogastric intubation with or without tube feeding. With loss of consciousness, the gag and cough reflexes are depressed, and aspiration is most likely to occur. Other high-risk groups are those who are seriously ill, have poor dentation, or receiving acid-reducing medications. Patient teaching. Patients should continue to cough and deep breathe after discharge. Coughing is less painful and more likely to be effective when the patient splints the chest during coughing, and fluid should be encouraged to help liquefy secretions. Symptoms of tuberculosis. Sputum specimens are obtained on 2 to 3 consecutive days for bacteriologic testing for M. tuberculosis. Chest x-ray examination is important, but it is not possible to make a diagnosis of tuberculosis solely based on chest x-ray findings because other diseases can mimic the appearance of tuberculosis. A high-efficiency particulate-absorbing mask, known as a HEPA mask or an N95, is used rather than a standard surgical mask, and it should be used when entering a patient's room because the HEPA mask can filter out 100% of small airborne particles. Patients who receive the BCG vaccine will have a positive mannitol test. Looking at the meds, orange-colored body secretions are a side effect of rifampin. Alterations in red-green color commonly occurs when taking ethambutol, which is a different TB med. Yellow-tinged skin could be a non-infectious hepatitis, and it is a toxic effect of INH, rifampin, and pyrazinamide, and patients who develop hepatotoxicity will need to use other medications. Discharge teaching. Teach the patient how to minimize exposure to close contacts and household members. Homes should be well ventilated, especially the areas where the infected person spends a lot of time. While still infectious, the patient should sleep alone, spend as much time as possible outdoors, and minimize time in settings like public transportation. Homeless person can arrange for meds to be given during a noon meal at a community center or a rescue mission. If on follow-up the patient is still positive for TB, check for compliance with drug therapy. If they have been consistent, then may need to change the regimen. Because smoking is a major cause of lung cancer, the most important role for a nurse is teaching patients about the benefits and means of stop smoking. CT scan is currently being investigated as a screening test for high-risk patients. To promote gas exchange, patients after a pneumonectomy are positioned on the surgical side. Frequent deep breathing and coughing are needed after chest surgery to prevent atelectasis. Early mobilization decreases the risk for postoperative complications such as pneumonia and deep vein thrombosis. In a pneumonectomy, chest tubes may or may not be placed in the space from which the lung was removed. If a chest tube is used, it is clamped and only released by the surgeon to adjust the volume of serosanguinous fluid that will fill the space vacated by the lung. If the cavity overfills, it could compress the remaining lung and compromise the cardiovascular and pulmonary function. And daily chest x-rays are used to assess the volume and the space. The review of the meds that I posted on the board: the bevacizumab, used to treat non-small cell lung cancer. Carboplatin and cisplatin, it is chemotherapy drugs that contain platinum. It is used alone or in combination with other medications to slow or stop cancer growth. Docetaxel is a member of the family of drugs called taxanes. This drug works by slowing cell growth. Erlotinib may be used in patients who have lung cancer, as it works by slowing cancer cell growth. A pneumothorax. Insertion of a chest tube is needed when there is absent breath sounds on one side. The dressing is taped on 3 sides and will allow air to escape when interpleural pressure increases during expiration, but it will prevent air from moving into the pleural space during inspiration. Placing the patient on the left side or covering the chest wound with an occlusive dressing will allow trapped air in the pleural space and cause a tension pneumothorax. The head of the bed should be elevated 30 to 45 degrees to facilitate breathing. Tension pneumothorax will require immediate treatment to avoid death from inadequate cardiac output or hypoxemia. Flail chest. Paradoxic chest movement indicates that the patient may have flail chest, which can severely compromise gas exchange and rapidly lead to hypoxemia. May need an emergency pericardiocentesis. The chest wall should be stabilized with tape, and a bronchodilator can help. Reviewing of the chest tube. Check the dressing, pneumohemo. A physician is responsible for chest tube placement and includes covering the insertion site with sterile petroleum gauze, a 4x4-inch gauze, and a large dressing to form an occlusive dressing supported with an elastic bandage. Monitor vital signs, pulse ox, and insertion site every 15 minutes for the first 2 hours. Initially, they may have subcutaneous emphysema at the insertion site, but the body can absorb. Avoid dependent loops. You want to lay excess tubing horizontally on a mattress next to the patient. Secure with a rubber band or the system's clamp. Prevent excess tubing from hanging over the edge of a mattress in a dependent loop, and drainage should not collect in the loop, as this could occlude the drainage system. Do not strip or milk the tubing. Stripping or milking chest tube only if indicated. This means compressing the tube to encourage clot to press through the tube. Stripping may cause complications because it creates excessive negative interpleural pressure. Check the drainage. The large amount of blood that suddenly shows in a chest tube might indicate the patient is in danger of developing hypovolemic shock. Look for bubbling in the water seal. A large air leak would be expected immediately after a chest tube placement for pneumothorax. Subcutaneous emphysema should be monitored, but it is not unusual in a patient with pneumothorax. A small amount of subcutaneous air is harmless and will be reabsorbed. Continuous bubbling is expected in the suction control chamber and indicates that the suction control chamber is connected to suction. Look for tidling in the water seal as it rises with inhalation and exhalation, but it is the reverse when it's on a ventilator. Check the water level. Adjust for gentle bubbles and make sure the tubing is open, mainly because they can develop a pneumothorax if the tube becomes disconnected from the drainage collector or dislodged. Pleural effusion. The patient would receive a thoracentesis. The upright position with the arm supported increases lung expansion and allows fluid to collect at the lung bases and expands the intercostal space so that access to the pleural space is easier. When the patient is sitting up, fluid accumulates in the pleural space at the lung bases and can more easily be located and removed. The patient does not usually require sedation for the procedure, and there are no restrictions on oral intake because the patient is not sedated or unconscious. Usually only 1,000 to 1,200 mL of pleural fluid is removed at any one time. Rapid removal of a large volume could result in hypotension, hypoxemia, or resulting in pulmonary edema. SAT should improve after a thoracentesis. If they decrease, then the patient may have gotten a pneumothorax. When the pleura becomes inflamed, the layers rub together, causing chest pain. This is known as pleuritic pain. Pleurisy is sometimes called pleuritis. Viral infections are the most common cause of pleurisy, although it can be caused by bacterial. Viruses can cause infections in the lung, which in turn can lead to pleurisy. So the nurse would need to listen for a pleural friction rub and or decreased breath sounds for pleurisy or a pleural effusion. Treatment is antibiotics in the case of a bacterial infection. Over-the-counter medicines could be taken like ibuprofen or cough medications, and sometimes it would be a codeine-based cough syrup. Atelectasis. This is defined as a collapse or one or more areas of the lung, whereas pneumothorax is the presence of air in the pleural cavity. The pleura is a double-layered protective covering which lines the outside of the lungs and the inside of the chest cavity. The space between the layers of the pleura is called the pleural cavity and separates the lungs from the chest wall. Atelectasis is caused due to obstruction of air passages by presence of foreign bodies, mucus plugs, tumors within the airways and in the walls of the airway. Atelectasis can also occur in premature babies due to absence of surfactant.